Hello and good morning or good evening, depending on where you are in the world. We'd like to welcome you most wholeheartedly to the Consortium of Universities for Global Health, our session on children in war, where we're going to be exploring lessons and stories from speakers from around the globe focused on what is happening in the world with respect to children in war. Um, so, regardless of where you're joining us from, and your field of work, we are thrilled that you are here to partake in this discussion. The motivation for this work and this panel today, is essentially that we are facing unprecedented levels of violence, unlike anything that we've seen since the end of the Second World War. And beyond the civilian harm that is happening around the globe, the majority of the harm that is happening, regardless of where you are or what conflict you're focused on, is on children. And so, like, as we begin to think together and listen to these speakers, one of the things that I'd like to draw our attention to is that we are moving into more and more global conflict, as we are all aware. And as recently as a week ago, the highest ranking general of the French army, said that the mothers of France should prepare to lose their children in reference to the potential expansion of Russian aggression, um, resulting in potential that NATO countries need to respond in war, which turned my entire body to goosebumps, because we are not only facing conflicts in Gaza, in between Russia and Ukraine, and as our panelists in this first section will speak to, across Africa. Um, and the second thing that I wanted to share with you, a thought, is that war is a disease. And as I was reflecting on this panel and beginning to speak with the panelists and think about how we wanted to shape this session, one of the things that occurred to me is symbols of healing. And I wanted to show you, since I'm not using slides in my opening remarks, this symbol from the crest of the Stanford School of Medicine. And on this part of the crest, you see um, the staff of Asclepius. And so this is a symbol of healing. It's the Asclepius was a Roman god who had a stick that he would use to cut the patient, to pull the worm out of the patient to save their life. And I think that as I've been reflecting on what this session can do, is that the panelists who are here today and you who are joining us online or listening to this later all have a role to play in tacking the world away from war towards a more peaceful future for humanity that's primarily focused on children. And with that, I would like to welcome to the floor Caitlin Howarth. Caitlin is the director of Yale's Humanitarian Research Lab, which is one of the preeminent forces tracking conflict around the globe, focused most closely recently on Ukraine and what's happening with the kidnapping and deportation of children out of Ukraine into Russia. But her group is also focused on Sudan. And with that, Caitlin, I'd like to welcome you. Thank you for coming, and we look forward to hearing your presentation.
Thank you so much. It's really a real honor to be among such a distinguished group of colleagues here today. The work that our team has been doing, and I'll focus mainly on Ukraine, but I'll touch a little bit on the situation in Sudan as well. I know that there's many who are going to be able to speak across these conflicts. Um, our team has been documenting the situation with Ukraine's children since 2022. And in that context, it's important to keep in mind that there are any number of ways in which Ukraine's children have been deeply impacted by this conflict. Our team has been focused primarily on the forcible transfer, the indoctrination, militarization, and other ways in which Russia is attempting to essentially Russify Ukraine's children through any means possible. So in that way, we focus on four groups of children. There are those who are taken along the front lines of the war. These are children who we've seen sometimes taken after their families have been killed. Um, there are those who are, and then the children are effectively captured by Russian forces. There are children who are taken through essentially a ruse, and it's a mix. It's often a very muddled situation where, in the context of the front lines, there are these camps that are offered as a rest opportunity, places where children can get away from the front line, from the stress, and from the privations of war, where it's hard to get access to fresh food, just to opportunities to play, just to be ch children. Um, and so Russia has set up these camps further away in occupied Crimea and elsewhere. And children are offered the opportunity to go and stay there, usually for up to 2 weeks at a time. And earlier in the conflict, it was clearly established that they would be able to come back from these camps. Now, when children are sent there by their parents, uh, in many, many cases, we've documented that these children subsequently do not come back, and that their children's whereabouts, their well-being, and any circumstances of their location, their health, and their status is then withheld from their families, and the children are subsequently told that their families no longer want them, that they will not come get them, and that they're essentially forsaken. Um, which is those are some of the most psychologically distressing situations that you can put a child into, tell them that their family has given them up. A third group are children that are in institutions. These are some of them are orphans and no longer have family. Many of them do actually have family, and they are in state-run institutions, either because they have severe disabilities, they may have intellectual disabilities, and some are simply there for temporary care while their family are going through struggles of their own. But these children have often been targeted by Russian state actors and occupied government actors, and then taken from those locations, moved through Ukraine into Russia, and then listed subsequently for adoption or fostering in Russia. And we've seen cases where there have been opportunities for their names to be changed, for them to be taken through and like given Russian passports, essentially for their identities to be changed. Um, and then the last group that we're really concerned about, because this is where the numbers grow exponentially, are children who are pushed essentially in just one direction through the course of the war, through the filtration processes. These are centers that are set up along border regions where families are given only one option, which is in order uh, to escape the front lines, they're told you can evacuate, but only in one direction. You can go east into Russia itself. And in the filtration centers, we've already documented in previous reports that men of military age are systematically separated from their families. We are now also able to see that there are cases where women and their children are also separated from each other, and the children may be then taken into Russia's overall system of forcible transfer. So, in all of these cases, and this is where we're seeing the potential for the numbers to truly skyrocket. So, we've documented at least our rough numbers that we're putting it at go up to about 19,000 that we've stated. Our upper estimate is at 35,000 that we believe is sort of like the upper end of number of children that we're tracking. And we're actively working right now on continuing to update those figures in our overall caseload. But the true number is probably in the hundreds of thousands simply because of the scale of those filtration operations. We're talking about a population of over 1.6 million children that are within the temporary occupied territories of Ukraine to begin with at the outset of the full-scale invasion. And Russia, by its own accounts, has said that they have 700,000 Ukrainian children within its borders. So, with that, to keep that in mind, um, that's sort of the scope of what we're seeing. And these are children who are then systematically put through indoctrination programs at every step, whether they're in the occupied territory, whether they're then in camps, or in institutions within Russia, or in schools, cadet programs, military camps within Russia. And so this is essentially a one-way pipeline that Russia is trying to take Ukraine's children, and not only turn them against their own country, but to actually feed them back to the front line itself, and to put them back to work in the war against their homeland. With that, I'll hand it back over to you, Ruth.
Thank you, Caitlin. And one thing I wanted to note for those listening online is that as you read the news and read about peace agreements, the all for all prisoner exchange that will hopefully eventually happen, essentially the arguments that Putin will make is that the children that have been taken are now Russian because he has a demographic problem. But the work that Caitlin's group and the Yale Humanitarian Research Lab is doing is they are tracking these children to understand where they've gone so that when we do eventually get to peace, that these children can be returned. So, Caitlin, it's nothing short of remarkable the work that you and your colleagues at Yale are doing. Including those that are working in the backdrop to make this happen in Ukraine and elsewhere. So thank you.
Thank you.
And with that, I would like to welcome Dr. Tunde, who's a friend and a remarkable pediatrician from Nigeria. He is based at the University of Ibadan. We've gotten to know each other quite well over the last couple of months as I've learned more about the complexities of delivering pediatric care in northern Nigeria. And Dr. Tunde, we are absolutely thrilled to have you here. And we look forward to hearing what you have to share with us today.
Can you hear me? Yeah. Yeah, thanks, Dr. Ruth Gibson, for that most kind introduction and for inviting me to join this panel and discuss this most important topic today. I'll be sharing with you this afternoon a perspective and experience from Nigeria, which is fragmented though, but I'm sure you'll be able to relate with some of the things we'll be sharing. I'll just share a little slide presentation that I just put together. Can you see my screen, please?
Yes, we can if you want to put it in presentation mode.
All right, good. So we're talking about children in war zones. Nigeria is not at war, but our situation is probably worse or pretty much the same as kids at war. And like Ruth said earlier, I work as a pediatrician in Ibadan. Ibadan is like 150 kilometers thereabout up north of Nigeria, up north of Lagos. And our own concerns has really got to do with terrorism and the offshoot of poor management of terrorism, in my own opinion, and how it has affected children. And we'll be looking at how we all can come together to improve the plight of these children. So the picture that you see is what typifies the northeastern part of Nigeria, where the Boko Haram team have been in operation since 2009. But as I'll go on in the presentation, you'll find out that the terror that they've unleashed on the country and the people has gone beyond them, but other groups have been emboldened because of the way they've been handled in our part of the world. I don't have any disclosure or conflict of interest as I give this talk. And that's a short or brief outline of my discussion. So let me start with a story that is online and we can all look it up, and there are many like this. And I give this story because a friend of mine says at times it's better to tell a story to drive your points home. And this is a story I came across a woman in part of the troubled areas of Nigeria. And our account was the usual pattern. They come in the night, they set the village ablaze, they separate the men, they kill them. And when they kill them, they don't kill them with gun or bullets or stuff. They actually slaughter them to make the death and they make their families watch them to make it more gruesome. Worse still, they abused the woman. And in this case, this was like a 12, 13-year-old girl that was raped next to her father's corpse, and her mom was forced to watch. And every time she looked away, she was slapped and told to look at it to see what the child was going through by the bandits. And after that, the girl was not herself again. Well, this is one of the many, 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 many stories that happen every day in our country in areas that are troubled by the Boko Haram insurgency and other bandits have come to the fore and are worsening the plight of our children. Now, Boko Haram, I term it terrorism unusual. And what does it mean? For some of us that might not know, Boko means anything education, westernization, anything that's got to do with the West. And Haram pretty much means forbidding anything that's an abomination, so to speak. So you have a group that have come to the fore and they're rooted in an ideology that is basically hatred for anything Western. So that's what the local guys call them because that's the way they've come across to the local guys. But the name actually says they're people committed to the propagation of the Prophet's teaching and jihad. Jihad, by the way, means forceful conversion to their religion. And this started in 2009 and it's fostered on till we speak. In the last 1, 2 months after President Trump declared Nigeria as a country of particular concern, there's been a remarkable upsurge of brazen kidnapping of droves, dozens of people. And it's been like that, you know. Now, what have they done? Basically, what they've done to press home the demands and what they stand for is to destroy anything that has to do with government. Schools in areas that they stay have been destroyed. Health facilities in the thousands have been destroyed. Government offices and establishments also destroyed in all those places. In some places, they've actually set up their own local government or caliphates, they call them. But along with that has gone the destruction of other ideologies or beliefs that are contrary to theirs. So Christians have come under very vicious attack. They killed in broad daylight their houses, their farms, their businesses, churches, their properties, anything that's got to do with Christians are destroyed in those areas where they control. As a collateral damage, the Muslims have come under attack recently because some of them have spoken up against what these guys are doing. So that's the kind of mayhem that is going on in that part of the country. Now, what has happened as a consequence of the assault? So there's been an assault on systems and structures. So like I mentioned earlier, schools and educational institutions have been destroyed. Health facilities have routine immunization and basic healthcare have been destroyed in most of those areas. Most of these communities are attacked are largely agrarian and they depend on their livestock or their farm. Now they've lost those farms and the means of livelihood, so you can imagine the amount of poverty. And of course, with that, there's been a large number of internally displaced people. We're looking at close to about 3 million at the last count, which figures might be an underestimation. Now, on the human part of it, what has been the effect on human beings? So there's been killing of citizens. Most affected have been women and children. Of course, the men too have been affected as well. There's been targeted killing of health workers. They actually at the time went after health workers and were killing health workers. And the result of that was abandonment of duty post or migration of health workers out of those troubled areas. Of course, with all of this has been very bad levels of malnutrition. In Nigeria, between 45 to 50% of the population have underlying malnutrition in children less than 5. With all that I've talked about, you can imagine how that has skyrocketed. There's been an increase in communicable diseases and infectious diseases from poor sanitation, overcrowding, poor access to immunization or health facilities. The mental health issues has been astronomical. The sad part of all this terrorist attack in Nigeria is that because those areas are not accessible, it's been difficult to really assess the impact of the damage. Of course, there's been a lot of abuse, drug abuse, sex abuse, and all of that. There have also been children conscripted into these groups by force and also by the civilian joint attacks, they call them. These are civilian groups that have come to organize themselves to kind of respond to all these attacks to the villages. And on both sides, they've actually conscripted children, underage children, to fight at the forefront and use them at times even as human shields or bombs to put forward their agenda and what they're doing. So there's also been a deliberate dehumanization and psychological trauma to all the people affected in these areas, because that probably leaves a more lasting damage to the psyche and the person than even the physical trauma. And I talked earlier about the physical, sexual abuse and emotional abuse that goes on in all those places. So this just shows a map of Nigeria, and it shows the hotspots. Those are the parts in red, and then the cold spots. And if you look at this, it tells us that the crisis is not just in one region. Yes, the hotspots are in the northeast where it all started from, but they actually have splinter groups and autonomous cells that operate in almost any part of the country, pretty much. So it's been a really bad situation for the country. Now, I talk also about the amorphism of the terrorism in Nigeria. And how do I mean? So it all started with Boko Haram, but then there's been a metamorphosis, so to speak, of all sorts of groups. So there are those that are Boko Haram, there are those that are affiliates of ISO, that's Islamic State of West African Province, that have linkages with those in the Sahel and the ISIS group and all of that. Then there are also bandits that have taken on the loose where the government has handled all of this to also perpetrate their own trade, so to speak. Unknown gunmen, they call them, but there are lots of talks about these unknown gunmen being used by politicians to cause destabilization and get one or two political gains. Then there are also separatist militant groups that go into conflict with their parent bodies and begin to operate autonomously. And then there are kidnapping networks, because it has become a very veritable source of income for these people and for criminals that want to latch on the current chaos that is ongoing. Now, the other problem with this issue that we have, it's very, the motives are fluid. There are all sorts of reasons. You have religious extremism, you have political violence, ethno-communal conflicts, economic desperation, local grievances, and all of this even makes it more complex to address. Then lastly is the changing nature of the pattern in which they engage. So you have some that have been split into factions. You have some autonomous cells that are operating for whatever reason. You have mergers and regrouping for opportunistic alliances or to reinforce territories. They hang on territories. And then there are also freelance actors, and then they kind of develop shifting methods to perpetrate the mayhem on the populace. And what still is the fact that there's some evidence and concerns there are local collaborators within the communities that are affected and also amongst government functionaries. In the last 1 month, there's been the news of an army general, brigadier general, that was ambushed. And he got out of the initial ambush and sent his location using WhatsApp to security forces. I told them how to come get him out. And that information got into the hand of the bandits, and they came after him and shot him. They took the videos and all of that. That goes again to reinforce the fact that they're actually people that are collaborating with these bandits within our security agencies. Now, specific impact on children, you would imagine the amount of malnutrition that's going on in those places. Lots of children are out of school, sexual abuse. Sexual abuse comes in different forms. Rape is one of it. Forced marriage is another one, because the bandits are promised that if they can do what they've been asked to do and kill innocent people, they get to receive these wives as these young girls as a reward. Some of the girls are actually taken along and used as sex slaves. Some are used to trade-offs and cut deals with other partners that are working with them in all those areas. I've talked earlier about child soldiers. Infectious diseases, we don't know the magnitude of the outbreak of infections in those settings, but there's been reports of measles. I'm going to show some slides of the diphtheria outbreak in Nigeria that is ravaging the country and has lingered on since 2022. And that really speaks to the decimation of our immunization system from COVID and all of that's happening in the northeast and northern part of the country. With all of this, you would imagine that we're stunting and poor nutrition and all the children are going through. There's a direct assault on their development, and that ultimately impacts on their ability to achieve their full life potential. And these have long-term consequences on these children and the communities. Of course, there's been a massive increase in mental health issues, anxiety, depression, post-traumatic stress disorders, substance abuse. Some of this is deliberate to make the children do the biddings of their captors, and then basically lost childhood. Now, this slide just wants to show you what's happening with respect to vaccine preventable diseases. So the first slide on the top is a study that looked at the Nigeria Indicator and AIDS survey, and they took samples and did analysis of some vaccine antigens to see the levels of protection. And you can see that in the northern part of the country, right from 0 years to 14 years, they carry the highest brunt of low protection, right? For tetanus, and tetanus is a good marker of having had contact with some form of immunization. And then lower down is the epidemic curve for diphtheria that's been going on since 2022. Diphtheria, by the way, it's a vaccine preventable disease with a very potent and efficient vaccine. But this map just tells us that there's been underlying disruption of the immunization system and is right across the whole country. 36 states of the country have reported cases, and as I speak, there's still ongoing reports of these cases. There's been high mortality. More than half of them are actually confirmed cases, which, though most of them are clinically confirmed, but you will understand that because of the lack of diagnostic platforms, there's a limitation to how much can be actually confirmed in the lab. Majority of the cases have been in children, and mortality is pretty high. For malnutrition, to assess the magnitude of malnutrition in those communities has been a challenge, but background data suggests that up to 2 million or more of Nigerian children have severe acute malnutrition, and just about a fifth of them have access to the treatment that they need. We have a population of IDPs of 3 million, probably more than that, and there are all various forms of malnutrition going on in those camps. Some studies comparing children from IDPs and their native host countries has shown that there's like 57% increase in the likelihood of severe acute malnutrition amongst those that come from those the displaced population and the home population. That's just like a proxy to tell you the magnitude of malnutrition going on in those settings. Now, what are the interventions that are needed? First, for me, I think there's a need to halt the onslaught. It's gone on for too much and for too long. I grew up in the northern part of the country, and from way back in the 70s, the 80s, we've had similar snippets of this kind of activities that we see. And unfortunately, to date, very few, if anybody, has been held responsible. And I think that's one big intervention that we need to push for. So in the last 2-3 weeks, with the designation of Nigeria as a country of particular concern, the government has been frantically making changes in its security architecture, in their number of the ambassadors and their foreign embassies and all of that, to try and make a change, a difference, which I think is rather late. Yes, it's better late than never, but it had to take that push for us to begin to see changes, right? And the kids really need us to help them stop that. So I think that's one of the main things that we need to do. I don't know how we're going to do that, but that's urgently needed. There's a need for education because many demographic health surveys and all the surveys have shown that underlying child health indices is maternal education. And one of the big onslaughts of the Boko Haram groups has been to prevent women from having access to education. And that's a big, big problem for me. Of course, we also need to talk about nutrition, right? And nobody says those kids don't want to go to school. We've had records of just recently this year, 3 kids from that part of the country actually got a global award on an English competition in the UK. That's to tell you the potential out there if they're just given the opportunity to express themselves. Nutrition, there's a need for nutrition, health facilities, there's a need for housing. I'm being mindful of my time, sorry. There's a need for livelihoods. A lot of the people in those places have lost their livelihoods. They can't farm, which is what most of them do. Many odd jobs in the cities they can't do because of all the insecurity in those places. And there's definitely a need for rehabilitation, both physical and psychosocial rehabilitation. And I'll just go briefly into pathways that I think we can engage as a people, as a community. And again, thank Dr. Ruth Gibson and her team for putting a spotlight on this condition. And that's because I believe that people are really keen and honest about wanting to do something. And I think that's very important. So do we need aid to help us resolve this? I've put aid and I've struck it out because I don't believe aid is a solution. Again, I don't think aid is a solution. Again, I don't think aid is a solution. Yes, there's a need for funding. Nigeria is not a poor country. If we prioritize the resources that we have and do the needful, I think that's the way to go. And that's why I want to ask that we demand accountability. I'm going to go into greater detail about that. And then we need also partnerships. We need partnerships like this to talk about these things, to look at them in a more holistic way and more scientific evaluation of the problem and how to resolve them. I think that's the way to go if you ask me. Now, what do I mean by accountability? The fact that this problem has gone the way it has gone for so long, and it has even evolved into a hydra-headed problem, it just speaks to the complicity of governments and places where this conflict exists. Just this week, Nigeria, for the first time since the onslaught of Boko Haram, released the list of funders and companies that fund Boko Haram. And you wonder that why did it take them so long to do that? There's a circulating clip on the internet. You could look it up. A sitting senator in the last regime is also in this regime on the floor of Nigerian Senate said he gave the president information about retired army generals using the bandits as a shield to mine solid minerals illegally in the country, and they bring in helicopters for supplies and take it out, and nothing happened. As I speak, nothing has happened against such a grave allegation, public allegation, in the seats in the Senate chamber of Nigeria. So a lot of people in Nigeria believe that there's complicity of government and government agencies in the continuation of this onslaught on the country and on our children. So we need to demand accountability from our government. We need our government to prioritize human development indices. I'm a Nigerian, and it breaks my heart when they talk about all the evils and the bad things that bedevils our country. We just got out of a 1 month strike of resident doctors shutting out health institutions, public health institutions all across the country. It speaks to the government failing to prioritize the things they need to prioritize. I grew up in the North. I went to university in the North. That's 30, 40 years ago, thereabout. And I've always known people in the North being offered scholarships for education, but it still remains the most backward part of the country when it comes to education. And I think that's because the leaders in that part of the country have not really done the needful to take the people out of poverty by providing them the kind of education and enlightenment that they need. And this is worsening again now with the Boko Haram and all the bandits and all the issues that we have. It's been a common pattern to attack educational institutions and take children out in their hundreds. We had the example of the Chibok girls. The Chibok girls is over 10 years now. Some of those children, those girls have never been returned or united to their families. You know, our government needs to look into wealth creation for our people. Nigeria has fertile arable lands. We have brilliant people that are ready to work, but we need the government to put structures in place to make them contribute to the country and to development. Women empowerment. I'm a pediatrician. I've seen it over and over again that for you to change child health indices, you need to empower our women. We need to give them the right of place and make them do the needful that they ought to do to take care of the children and contribute to nation building. And then we need our governments to be transparent, the actions to be equitable, and the interventions to be accountable. There's been all sorts of corruption and issues around corruption and poor management of all the crises that we have, even in trying to address what the Boko Haram and the other groups have unleashed upon the country. We need partnerships, and I think that's the way to go. We need partnerships to empower our women. How best can we empower women in settings like this in Nigeria? What kind of empowerment is fit for their own locale, right? What are the resources available that can be leveraged to empower these women to be self-sustaining, which is what every woman in that part of the country that I've come to interact with really wants. We need adaptive educational programs. So what has happened there means that the kind of educational interventions we're going to give is not going to be the routine or the regular kind of educational activities. There has to be educational activities for children, for adults that have lost out on the education that they ought to have had, educational activities for people that are migratory or nomadics, educational activities that will include other psychosocial needs of these children. Some of these children have physical disabilities, they've lost an arm, an eye, a leg, a limb. All those things need to be incorporated. Educational activities that takes the community along to define what they want for themselves and bringing on board religious and cultural leaders to have a role in whatever we fashion out for these children. Educational activities to help them stay in school and not live in the fear of the next gunshot or the next kidnap out of those school settings, right? So it has to be a custom-made educational activity for them. We need to work on health-seeking behaviors. Background in Nigeria, we have challenges with health indices because of education and the impact that has on health-seeking behaviors. What models can we develop to improve health access and equity in these places that are ravaged by conflict in our country? Right. How best can we use the resources and the funds available to meet their health needs? How can we improve the uptake of maternal, newborn, and child health services? There's a place of culture, there's a place of religion, and there's a background history that pervades this part of the country. How can we improve on those innate challenges that we have now worsened by this crisis that we're going through? Those are things that we need partners and collaborators to come help think through and adapt something that works for us. What kind of health creation is important for that setting? I've talked about the fact that most of the people in these areas are agrarian in nature. Can we unlock the agricultural value chain to create value for the people in those places? It's not money alone that will do that. It takes a lot of science and innovative thinking and working with the people on ground. We need to rehabilitate. We need to reintegrate. The populations have been decimated by this crisis have lasted for almost 20 years or more going. So what rehabilitation measures do we need to put in place and how do we go about it? So I think what we need at this stage from all of us and all of you on this call is partnership on how to walk through this together with us. Is there hope? That's what I see in this young man asking. Is there hope? It depends on me, depends on you, depends on all of us. And I believe that's why we're here this afternoon. And I hope that this meeting today is going to bring something beneficial to a lot of children hanging on and hoping that sooner than later, hope will come for them. Those are my few references, and I thank you for listening. Thank you, over.
Thank you, Tunde. For me at least, I've heard Tunde speak more and more about the situation in Nigeria and the complexities of delivering care, pediatric care, dealing with infectious disease in light of forces like Boko Haram and bandit groups. I've learned a great deal. So thank you, Tunde. What I'd like to say to all of you who are with us right now online, I think that the main intention of hosting this live is essentially so that you can ask questions to our panelists. And beyond the questions that you are posing right now, part of what we'll get to as many as we can, but part of what you're telling us is what you want to understand with greater depth, because we do have these 2 hours together today, but we can also set up other panels and other sessions to speak more in depth about specific aspects that you're interested in. So please do enter into the question and answer chat the questions that you have. If you are open to saying who you are and where you're from, that's helpful for us to understand, but otherwise just enter it anonymously. We'll get through as many as we can after the next 2 speakers, but we'll also track what you're interested in. That's really helpful for us. And with that, I would like to welcome Dr. Martha Solomon. Dr. Solomon is a pediatrician at the University of Gondar. She was involved in the Tigray War, and so she's going to be speaking to us today about what's happening in the Amhara region of Ethiopia. And as I've been working on this panel, one of the things that's really startled me is prior to beginning to engage here, I didn't understand the severity of the crisis currently unfolding in the Amhara region. She's leading and working at the largest referring hospital in the region. And Martha, we're absolutely thrilled to have you with us today, and we look forward to learning from you.
Thank you, Dr. Gibson, and all the CUGH CUGH members, all of you, all the participants. You are doing an incredible job. You are saving millions of lives. You are representing those innocent segments of the population. So I'm so honored to be part of this international panel, and thank you again. So I'm going to show you just a drop of information from ocean like a problem. There is, it's called, in Amharic, we call it Abay and Bajalfa. You know, Abay is in Nile River. That's a drop of water from Abay. Okay, let me share my screen here. I'm going to present it with the slides presentation. Okay. Okay. So what are children? As a pediatrician, I have seen children health challenges during conflict in Ethiopia, during Tigray war, and still an active war. I mean, conflict is going on in Amhara region, some part of Oromia, between Tigray and Afar. There's still some problem. So the most vulnerable group of the population will be affected by this war. Those are children. Who I am, I'm a pediatrician, as I say, with 6 years of experience. Ethiopia is a landlocked country and second most populous country in Africa after Nigeria. I'm presenting also my case after Nigeria. I think it's well organized. I attended medical school at University of Gondar Hospital, and both my undergraduate and postgraduate program. I have a PhD in epidemiology, and I served the institution as community engagement director. My objective of this presentation is I want to briefly discuss my observation about how children's health has been put at risk during conflict in Ethiopia, particularly in the Amhara region. And this represents my perspective as a pediatrician, not anyone else. And I'm not a member of any political party. To begin my presentation, we will see impact of conflict on children's health in Ethiopia. It severely affects vulnerable population, particularly children, pregnant mother, and lactating mother. In Ethiopia, ongoing instability has disrupted essential health services like vaccination services, routine health care services. As a result, children face increased risk of disease, specifically malnutrition. When I say disease, vaccine preventable disease, and limited medical care. This observation highlights the urgent need of protect children who are living in conflict zones. As of 2025, as far as my knowledge, the primary conflict regions are Amhara, Tigray, the famous Tigray War, which kills millions of population, millions of population, yes, and Oromia and Afar. Some of the impacts to see those children living in Ethiopia are millions of children affected by displacement, food shortage, and collapse of essential services. Health facility in many conflict zones reported damaged, closed, and lack of supplies. UNICEF estimates millions of children require urgent humanitarian assistance in Ethiopia. Just to see some of the studies, there are many studies done. This is some of the studies. The effect of conflict on child and adolescent health in Amhara region. This is a cross-sectional study done and community-based study. 798 children aged less than 18 years were involved in this study, and more than 1/3 of children were displaced due to conflict, and 331, which is for nearly half of them, get disease, with the majority didn't receive treatment during conflicts, and more than 2/3 of they experienced violence of different types, and nearly half of them had acute malnutrition, and most of them had severe acute malnutrition. Another also study done in Tigray as well. This is also community-based. As a pediatrician, most of disease are vaccine preventable, and children under 1 didn't receive it. It was done community-based and done in thousands of children. It's also nearly 39% of infants receive no basic vaccine, 0 dose. And 61.3% of children under the age of 1 received at least only 1 vaccine. And about 61% children were affected by at least 1 childhood elements, where majority of them were from rural area, and mothers who didn't seek postnatal care also were responsible for more than 75% of reported childhood illnesses. So it's related. One of the impacts of the conflict that we have seen is displacement. Many families, millions, were forced to flee their homes, lose access to safe water, sanitation, shelter, routine health care. And there are IDP camps, specifically in Amhara region in Gondar. There are 2 IDP camps where thousands of individuals are living in it. For example, in the city, there is around Azazo in Gondar city, there is 1 IDP camp. More than 3,000 individuals are accommodated in that IDP camps. So there is limited mobility, reduces health access to vaccination and treatment services. In conflict-affected Amhara, 34.6% of children reported displacement, for example. The forms and adverse effects of insecurity among internally displaced children in Ethiopia are many. Of this, they face many challenges related to poor socio-economic conditions that expose them for several insecurities and negatively affect their well-being. They reported inadequate access to clothing, shelter, clean water, sanitary facility, food, and inadequate health care due to financial barriers, lack of basic drugs like antibiotics, and quality of care as well. So they are facing many health challenges among internally displaced children. Malnutrition crisis and man-made famine, very common. And in conflict, obviously it worsens food insecurity and disrupts aid distribution as well. In affected Amhara districts, 41.2% of children ranging from 6 to 59 months were malnourished. Most of them had severe acute malnutrition. And majority, more than 2/3, didn't receive any treatment. So this is also a bar graph that shows pre-war and post-war comparison of child with acute malnutrition is tripled, as you see. Those are forms of malnutrition, severe acute, moderate, and global acute malnutrition, and they are tripled after war. The occurrence of disease resulting from conflict in Ethiopia, we have seen outbreak in Gondar, measles outbreak, cholera outbreak, Nearly 2,000 were suspected for having a cholera after the conflict. Also, measles outbreak, very common, malaria also. So, devastating increase in vaccine preventable disease, specifically in northern part of Ethiopia and some part of Oromia as well. And chronic condition worsened during conflict in kids. Children on follow-up with diabetes, renal disease, asthma, they are facing more severe complications. For example, diabetes, they are facing diabetic ketoacidosis and unnecessary hospital stay due to restriction and unsafe land transport, increased risk of children contracting hospital-acquired infection and significant economical burden. 42% of children surveyed in Amhara, they experienced illness during conflict and didn't get a treatment. Fever, infection, diarrhea, also some of the mental health risks. Also there, yes, exposure to violence, family separation and displacement increases trauma and mental health risk. Some of the most common PTSD, even based on studies, anxiety, depression, and also this is a photograph taken from northern part of Ethiopia. This woman is grieving for her husband and kids. So this is very, very devastating. The conflict is having significant toll on young people's mental health based on this study as well. When compared to relatively unaffected regions like Addis and non-affected regions of Oromia, nearly half of them young people pilot in Amhara and a third of this living in Tigray reported symptoms of associated post-traumatic stress disorder. Gender-based violence and abuse, yes, weaponizing gender-based violence and sexual violence are very common among young girls and women, and girls migrate due to fear of this violence and weaponizing, forceful and abuse. Girls migrate to urban areas and become domestic workers. They become homemade, servants. So which predispose them for violence and abuse. This is also a study of girls and women who are undergone this sexual violence by using as a weapon for a war by military groups during conflict, and they were exposed to various forms of gender-based and sexual violence, psychological and social problems, complicated sexual and reproductive health, even ended up with disability. Health infrastructure destroyed. This is also an image taken from northern part of Ethiopia, from Tigray. Damage to health facilities and insecurity, block access to services, interruption in immunization, maternal and child health services, and treatment for chronic disease also there was a shortage. You can see the bullet holes. The other is educational disruption. Schools were destroyed, teachers were displaced, usually migrate to the cities, and loss of learning materials and safe learning spaces. Children, based on this report, children out of school due to conflict in Africa is very common. Those are the hot spots. In Ethiopia, around 9 million of children are out of school. They accounted around 80%. So what are long-term consequences? Stunting and developmental delay from chronic malnutrition, lost years of schooling, reduced future opportunity, obviously, and increased maternal and infant mortality. Call to action, way forward. We don't love AIDS, but we would like to kindly urge, since it is a temporary solution, we would like to kindly urge U.S. governors to reconsider stop or the cuts of USAID funding and other donations, because it's very important for temporary solution. And strengthening local child protection system, yes, this is very important. We have to, there should be international law that protect child should be enforced in conflict zones like ours, and partnership. Still, we love partnership with schools, health centers, and community groups with international community to save millions of lives. and supporting caregivers with resource and training, and coordinated efforts between the government, non-governmental organizations, international agencies, and I know there are many influential people here. So we are calling you to action. In conclusion, conflict severely harms children physically and mentally health in Ethiopia. Immediate action is critical to prevent long-term and irreversible effects. Specifically, we have to prioritize nutrition and vaccine and other protection and recovery systems are essential. Children's well-being must remain at the center of humanitarian assistance in conflict zones like ours. So I will conclude my presentation by saying safeguarding the future, no matter where they are. And those are some of the references. አመሰግናለሁ. Thank you.
Thank you, Martha. That's incredibly enlightening. And our last speaker for the first part of this session is Anas Mustafa. She is the director of Sudan's Ahad trauma centers. She is running trauma centers at 7 locations around Sudan, including the Darfur region. And we are absolutely thrilled that you're here with us today, Anas. One of the things that's coming up a lot in the question and answer feed as the speakers are speaking is some global policy recommendations for the overarching trends that we're seeing in terms of violence against children. So we're looking forward to hearing your thoughts now.
Hello, thank you all. And thank you, Ruth, for the opportunity. I hope you can hear me loud and clear. Yeah, thank you. So I will speak about Sudan. And in my presentation, I have few informations about the current situation in Sudan that most of the people, they don't know that what's happening in Sudan. So I'll speak about the war in Sudan, the civilians' impact and displacement, and about the trauma center. And my name is Inas El Hadi, and I'm a mental health specialist, and I work at the Ahfad Trauma Center. I'm the head of the Ahfad Trauma Center Outreach Office in Sudan. So basically what's happening in Sudan since 15th of April 2023, a violent war erupted in Khartoum, Sudan capital. And the war started between SAF, the Sudan Armed Forces, and the Rapid Support Forces, the militia. So the war beginning in Khartoum, the capital, and then spread it in the national-wide in around the states. Definitely, due to the war, hospitals, markets, schools, and water and electricity system, they were destroyed. And Sudan now is facing the world's largest internal displacement crisis and also a refugee crisis. Millions of people are trapped with little humanitarian access, those who are in the camps inside of Sudan. But definitely the numbers are different. So the humanitarian impact on the civilians, that 9.5 million internal displaced people, which is the largest number ever in Sudan, so that mainly people move to the other states for their relatives, but not a massive movement or any forced displacement, what was happening. 3.44 million refugees in neighboring countries. The hosting countries are within the border, sharing the border countries that from the beginning of the war, the Khartoum airport stopped. So the movement was land border movement, so that the most close to the border countries, those who were receiving the refugees from Sudan. And half of the displacement or displaced people are children and women. Civilians face hunger, trauma, loss of homes, and lack of care. And definitely in Darfur region now, the SAF are using the starvation as a weapon of war for the civilians who are trapped there. And also the use of sexual violence against women and children is being used as a weapon of war for the children. And also the issue of kidnapping women, kidnapping children, and making them like slaves at homes or sex workers or households. Many IDPs lived in overcrowded shelters. For those who are in camps in around the states, the situation is chaos for majority. So this is a map of Sudan for those of you who don't know. So Khartoum, the war started in Khartoum and then moved to Jazeera state, and then some part of the region of Blue Nile, the Sinnar state. And then it's all about, now it's all in Darfur region and some of Kordofan region. And if you see that the majority of the hosting countries or the other hosting countries like Egypt, Libya, Chad, and South Sudan, and also we have refugees in Ethiopia, and yeah, and Chad hosting the majority also because they sharing border with Darfur. So the people from Darfur region moved across the other country. If you heard about the catastrophic situation for the Sudanese people in Chad refugee camps, it's disaster. And also for those who are from South Sudan, also they are living in disaster in the refugee camps there. So these are the most affected regions in Sudan: Khartoum, Jazeera, Blue Nile, Darfur, and Kordofan. The other states also are affected by the forced displacement that happened in Sudan, especially for those in the Port Sudan and Kassala state here and here, and the Northern state, all the Northern state also hosting a lot of IDPs. So as what I said, I work at the Ahfad Trauma Center, and we are a specialized trauma center providing specialized trauma services. The center established in 2012 at Ahfad University for Women. It's seconded from School of Psychology and Preschool Education under the Trauma and Community Counseling Program. So we provide trauma counseling, community outreach sessions or community outreach activities, and we provide clinical training for professionals and for lay people also. So the trauma center used the model for trust, which is trust model, which is trauma resilience, upscaling services and training. For the current situation during the war, we tackle the short intervention models, that the telecounseling, the resilience building, the mobile platform to reach IDPs, refugees, women and children. So the services provided for all the communities, including children. We have specialized trained cadre that offers trauma-focused CBT and narrative exposure therapy and teaching recovery techniques. These techniques are for children used in the camps. So we operate mobile clinics, and we also do GBV responses and training programs for activists and social workers and whoever working the humanitarian sectors. So we are the Ahfad Trauma Center is now a key lifeline during Sudan 2023 war due to a lot of we already have a gap in mental health facilities in Sudan. So after the war, many cadre were out of Sudan. The health facilities itself, it's destroyed, and no proper treatment or no proper care for children or adolescents or even women. So Ahfad Trauma Center, we're trying to provide the best services that we can do. So the trauma center we operate in Durman, which is in Khartoum, the greater capital Khartoum, and we work in Kosti, which is the capital for White Nile State, and we work in Gadarif State, we work in Kassala State, we work in North and South Kordofan, and in Blue Nile and North Darfur. And recently, unfortunately, we lost the connection with the South Darfur with the North Darfur center due to the RSF are taking control of Darfur now, so its access is extremely limited in Darfur, and also the provision of services that, especially that they have destroyed the main only hospital specialized for providing GBV services for women and children. So these are some pictures for the current situation for those who never seen or heard about the situation currently in Sudan, pictures from the camps and picture for this is hospital had been destroyed and ambulances are being burned and children are scattered. And yeah, these pictures from the UNFPA and UNHCR and and IOM also have shared one of the pictures. So this is the contact information for the trauma center for whoever would like to contact us. And thank you for caring about Sudan and asking about Sudan and for the opportunity to speak about Sudan. And this picture is also from Sudan, the peaceful Sudan before the war. And it shows the confluence, the Blue Nile and White Nile confluence. And thank you.
Thank you, Enos. I really appreciate you being the representative of what's happening in Sudan and explaining to us more about what's going on and what you're doing to deal with this humanitarian catastrophe. We are running a couple of minutes over from session one, in part because I wanted to make sure as we were setting this up that we were covering speakers from every global conflict. And what I'm going to ask the four panelists from session one to do is I'm going to send you some of the questions in the chat to make sure that we can answer those questions that are coming up from all of those who are joining us online. And for those who have asked questions online, we're very grateful for your participation and input, and we will get answers to you from the panelists in the chat as we move forward here. So with that, Keith, I'd like to hand things over to you for a discussion about what's happening on the ground in Gaza.
Thank you very much, Dr. Gibson, and welcome everybody. That was a wonderful first session of outstanding speakers. Much thanks to all of you who have taken the time to participate in this really important CUGH online session that is virtual and open to everybody in the world. And this session, like all of the ones this week, will be shared globally, not only with our 36,000 person network, but also far beyond that. Now, as I said, I'm Keith Martin, Dr. Keith Martin, the Executive Director of the Consortium of Universities for Global Health here in Washington, D.C. And this session, the second part, is going to focus on solutions. And while we heard about the horrible situation in Nigeria, Sudan, Ethiopia, and Ukraine, this session, as Dr. Gibson mentioned, will focus on the catastrophe unfolding in Gaza. And I'm going to introduce the speakers in the order that they're going to speak. And I'm going to have a few introductory words. So the really outstanding panel that we have today of individuals who are extraordinary physicians in their own right, humanitarian physicians who have a lot of personal experience in the catastrophe in Gaza, and will share their views on how we move forward and how particularly the children affected by that catastrophe can receive the care that they desperately need. So first, we're lucky to have Dr. Clay Dalton. Dr. Dalton is an emergency room physician. He's a writer for The New Yorker, but I'd encourage you to Google his name and take a look at all of the other amazing things that he has published in many other platforms. It's really outstanding. He's been on medical missions to Gaza and in other parts of the world. Next up will be Dr. Ihab Halawash. Dr. Halawash is a pediatric surgeon at the Nationwide Children's Hospital, an assistant professor of pediatric surgery at Ohio State University College of Medicine. He has worked in Gaza both prior and during the current horrible situation. He has done many medical missions, and he emphasizes medical solidarity with local surgeons and through collaborative partnerships, hands-on training, mentorship, and enabling people to have dignified care. Finally, we have Dr. Feroz Sidwa. Dr. Sidwa is a general and critical care surgeon. He is also board certified in neurocritical care. He is a humanitarian surgeon who's worked extensively in Palestine, in Ukraine, but also in Burkina Faso, Zimbabwe, and Haiti. So you can see all three of the speakers we have today have extensive experience in Gaza, and we will look forward to listening to them about how we can move forward. But first, a couple of comments. And I wonder, Elizabeth, if you could put up my presentation. I just have a couple of slides and a couple of points I'd like to make before we start. While Elizabeth is doing that, I would just encourage you that this is a full week of virtual sessions, 16. They're open to all, and you can register for them at CUGH.org. I would also encourage you to come to our conference, which will be in Washington, D.C. next April 9th to the 12th. And we hope that you can come there and work with individuals from around the world who are addressing contemporary challenges, including the one we're dealing with today. So, Elizabeth, could I have the first slide, please?
Yeah, Keith, can you see the title slide? Just wanted to
Yes, I
make sure.
can.
Okay,
I got
great.
it. Thank you, Elizabeth. All right. WCNSF. WCNSF. Wounded child, no surviving family. That is a horrible, horrible acronym that is the reality of children today and these children in Gaza. And the depth of the tragedy of these children and the Palestinian people and what they're suffering today in Gaza, the fact that this acronym was actually put together to put some label on these children to find some way forward is a tragic and horrible indication of the trauma these children are facing and the future that they face. What will happen to these children? Although more than 20,000 children have been killed in Gaza and more than 40,000 have been officially injured, in reality, there's more than 1 million children have been traumatized in Gaza. There's nothing in Gaza. It's been devastated. So what is going to happen to these children? If you look into the eyes of these children, what will happen to them? If they were your children, what would happen to them? So the goal of this particular session is to figure out and advance a way for these children to be able to have the care and the dignity of the lives that they deserve to have, that they must have, like any children anywhere in the world. Next slide, please, Elizabeth. Here's the numbers that we know of. In Gaza itself, as I mentioned, more than 1 million children traumatized, more than 40,000 injured, some with horrific injuries that we'll hear about now. In Sudan, you've heard from our speakers before, thousands have been killed, 24 million children have been traumatized. And as you heard from our previous speakers, whether they're Nigeria, Sudan, Ethiopia, or Ukraine, we're living in a world of children that are being traumatized and who have no recourse to protect themselves at all. Next slide, please. So what happens to this child? What happens to her? How does she receive the care in an environment where there is no care? Next slide, please, Elizabeth. So here's one thing I want to posit. And I've actually approached the embassies in Qatar, UAE, and Saudi Arabia. At least now, at this moment in time, that's a part of the world close to where Palestine is, where these children can receive care. And perhaps if those who are listening to this from those countries, that they can think through how they can provide with the extensive facilities and resources that they have, that those children can actually receive the care that they need with their families and then be able to return back to Palestine as they wish. So I'd like to turn it over now first to, can I have one more slide, please, Elizabeth? Yeah. So if you'd like to help, here's just a few of some of the groups that I support and know. So some people ask, what can we do if we're living far away? Here's just a few, and there's many others where if you'd like to make a contribution, you can do so to help these folks. With that, I'd like to first turn it over to Dr. Clay Dalton, who will turn it over to Dr. Halowish, who will turn it over to Dr. Sidwa. Clay, Ferris, and Nihab, thank you so much for joining us today. We're deeply honored, and I'll turn it over to you, Clay, first. Thank you.
Thank you, Dr. Martin. I just want to say thank you for the opportunity to be here and speak about the devastation in Gaza. As Dr. Martin mentioned, trained as an emergency physician. I'm also a journalist. And I traveled to Gaza during the second ceasefire, which was January to February of this year, and engaged in clinical care of patients in the emergency department, but also spent a considerable amount of time traveling throughout the north, central Gaza, and surveying the damage of the healthcare system there, which is something that I've written about. And I'm going to focus my presentation today on that. It's extremely difficult to provide medical care if you don't have the infrastructure to do so. That's sort of the basic starting point for caring for children who are victims of starvation, victims of traumatic injuries from airstrikes, victims of other sort of second and third order consequences, health consequences from the conflict. This might be infectious disease. It might be something like diabetic ketoacidosis for insulin-dependent diabetic adolescent or child who can't access their insulin because the entire healthcare infrastructure has been damaged. And so I'll take you through some slides from our mission into Gaza, just to really sort of illustrate the extent and severity and degree of damage to the healthcare system in Gaza. It's truly extraordinary. And I think in terms of focusing on solutions, this is a really important place to begin in terms of restoring the ability of healthcare workers in Gaza to care for not only the children of Gaza, but the entire population. And it's going to be an extraordinary effort to rebuild what is there. Although I will say that even during the ceasefire was only days old when we entered the second ceasefire. And already people were working to rebuild the healthcare system with what little they had. It was extraordinary. And so provided with the support, the resources, the funding, the material, the equipment, I have no doubt that the people there will be able to restore the healthcare system as best they can. So I'll move into sharing my screen. Okay. Dr. Martin, are you able to see that screen?
Yes,
Yes,
I
we
can.
can.
Thank you, Dr. Dalton.
Thank you. So we'll begin here. So these are the dates of our mission. It was actually quite a short mission. It was slotted to be 2 weeks, but we were delayed in terms of our entry crossing into Gaza by several days. And so it was a shorter mission than most. And this is how we go in. People who have been on missions into Gaza probably recognize this scene. This is the Kerem Shalom crossing. And we made it on foot. You can see we're all carrying suitcases. It's all just full of medical equipment. Anything that we could carry, we brought with us. And on the other side, this is one of the things that we saw there was the consequences of displacement, internal displacement. This is a school that had been turned into a sort of makeshift shelter for probably hundreds upon hundreds of families. This is in central Gaza in Deir al-Balah. It's empty because once the ceasefire was announced, many of these people who had been displaced from the north were able to return back to the north. But you can imagine this sort of, I think, captures the degree of displacement within Gaza, and you can imagine the consequences for healthcare, medical attention when people don't even really have a place to live. In terms of additional consequences of displacement, these aren't patients These are just individuals who have nowhere to live, and who have been, I suppose you could say, fortunate enough to secure an extra stretcher or a bed or a cot or even just a pallet on the floor in corners of the hospital. And so the stairwells of the hospitals were sort of full of makeshift tents, sheets draped in the curtain for some semblance of privacy. And so this was, for these individuals, this was a relatively safe and dry and clean and warm environment. And then starvation. This is not one of my photographs, because when I was there, aid was flowing into Gaza, and for the most part, there was adequate nutrition for most of the people who were there. Famine and starvation came later in the year after we'd already left, when food aid had been restricted. And the consequences of starvation are quite insidious, actually. This is something else that I've written about. The sort of acute consequences can be visibly very striking, and of course can cause death and disability and other complicating infections, so on and so forth. But there's actually a very long sort of tail of consequence, particularly for children if they've been exposed to periods of starvation. Even after the period of famine or starvation comes to an end, there are long-term consequences that seem to be locked in essentially for life. The younger the child, the more significant the consequences, primarily because children have such limited reserves when it comes to calories and nutrition, and because they are still developing. Their organs are growing, their brains are growing. And so if you deprive them during these periods of critical growth, then you can increase the risk over the lifespan of chronic metabolic diseases, cancer, mental health problems, etc. And in fact, the most vulnerable group is actually children who are in utero during the period of starvation or famine. So these are unborn children who were not directly exposed to a famine or a period of starvation, but their mother was. These individuals are very susceptible to increased risks throughout their entire lifespan. And so we'll move into some of the direct documentation of the consequences of the conflict for the healthcare system in Gaza. This is along a coastal road headed to the north. And so the hospital where I was based, working clinically, was in central Gaza, in Deir al-Balah, Al-Aqsa Martyrs Hospital. And I felt that it was quite important, if at all possible, to make my way north and to document the damage to the healthcare infrastructure in the north, for a few reasons. One, because many of the most important centers, hospital centers, referral centers, specialty centers, are in the north in Gaza City. And two, because this region had been subject to the most intense bombardment and devastation. And we had heard that the hospitals and healthcare infrastructure in the north had borne the brunt of the damage. And so this is me and a local coordinator for the organization that we were working with, making our way to the north. And you can see there are people who are traveling with essentially everything that they have left: pallets, beds, things of that nature. And the degree of damage in the north was extraordinary. This is representative. This is from one of the northern towns to the north of Gaza. And it's just a sort of uniform destruction, really, as far as you can see. There's almost nothing that is untouched, unfazed, and very little that is standing. And so it's hard to imagine people still trying to find shelter in places such as this. This is in Gaza City, outside of Kamal Adwan Hospital, which was subjected to direct attacks, shelling, airstrikes, and then was raided by Israeli forces, and then the hospital facility burned. It's not entirely known how that fire broke out, but walking through a burned hospital was especially disturbing. And you can see just the scale of the destruction is quite remarkable. In the back corner here, this is infant formula that had been destroyed. And you can see probably a crib here, medication vials on the floor. Patient rooms had been burned and destroyed. Moving up through the hospital. And Kamal Adwan Hospital had one of the few neonatal intensive care units in northern Gaza, which had also been destroyed, as you can see. So there are incubators here, panda warmers that had been destroyed. This is the operating room in Kamal Adwan Hospital as well. So also, as you can see, everything has been burned and destroyed. And then this is Al Shifa Hospital, which is probably the most important medical facility in Gaza. It's in Gaza City. It is the sort of flagship teaching hospital in Gaza and also a very important referral center. So many specialty services are available here. This is an earlier photograph of Al Shifa Hospital during the conflict. And you can see that there are a number of people who have actually taken shelter in the courtyard, just on the impression that this would be a sort of safe haven, which has not proven to be the case in Gaza. Medical facilities there have been subject to targeted military action. And then by the time we arrived at Al Shifa during the second ceasefire, it had been subjected to tank fire, shelling, airstrikes, direct military raids. And this is what it looked like when I arrived. Totally abandoned for the most part. There was the director of the emergency department had sort of reopened a makeshift emergency room in an outpatient building. And that was really the extent of the services that were offered there at the time. The main buildings had been completely destroyed and were totally abandoned. This was what was left of the old emergency department in Al Shifa Hospital, which was only actually a few years old before the conflict started and was equipped just like any sort of modern Western hospital emergency department, expansive, quite large, very beautiful, clean. You can actually see, this is the director of the emergency department, Motaz Harara. And you can see this is a photograph of what the emergency department at Shifa had formerly looked like from essentially the same perspective where we were standing. Quite a change. This is a makeshift graveyard that you can see outside the back wall that has been blown out of the emergency department. And this is something we saw at every medical facility that we visited throughout the North. These would be patients who died when these facilities were under siege and there was nowhere else to bury them. They would be buried in courtyards, passageways, really any sort of spare patch of dirt. This is another one of the buildings at Shifa, which was totally destroyed. This is the main lobby or atrium of Al Shifa Hospital. A few other photographs. This was the front entrance. This is a makeshift grave at Indonesian Hospital, just to give you a sense of how limited they are. So we'll often see graves were marked with writing on a wall or on a piece of paper or a ceiling tile or a piece of rubble or debris. And then this is one of the more disturbing things that I witnessed on my time in northern Gaza. This is an Indonesian hospital. And in this facility, we were shown a room that was filled with discrete pieces of medical equipment, IV pumps, cardiac monitors, ultrasound machines, dialysis machines, et cetera, that seemed to have been systematically destroyed with gunshots directly into the screens. It's hard for me to imagine that this might have been collateral damage. It certainly seemed systematic and intentional. A few other devices. These are dialysis machines that were destroyed. And then I think just to close, what I'd like to focus on is, all of these various different ways in which the conflict has impacted the population in Gaza, destruction of the healthcare system, starvation, displacement. These burdens fall disproportionately on children just because there are so many of them. It's nearly half the population of Gaza. And so the toll that this conflict has taken on the population of children there is extraordinary and really hard to articulate, hard to grasp. And I also, while I was there, I saw many scenes of resilience, children finding ways to play and to continue to live their lives in the midst of the rubble. I saw children flying makeshift kites. Here we see children building presumably a little fort out of pieces of rubble, detritus. And so it was an extremely poignant reminder to me that children are incredibly resilient. And if we are able to support them in what they need, adequate nutrition, food, medications, healthcare infrastructure, the things that we take for granted in many other parts of the world, then they will find a way to thrive even in the midst of incredible hardship. They just need a little bit of help from us. And so this is us departing, again, walking out as we came with mostly empty suitcases, leaving as much as we could. And that's my final slide.
Thank you very much, Dr. Dalton. That was a poignant. Thank you for your service, number one, and thank you for sharing. It's difficult. I can't imagine. But in sharing, you're giving voice to the voiceless, and we're truly grateful for that.
Thank you.
If you're able to stay for 10 minutes after, because I know you're in a tight timeline, that we'd appreciate that. But if you have to go, please do. And with that, it's our honor to turn it over to Dr. Ihab Halawish. Dr. Halawish, thank you very much for joining us today. And the floor, sir, is yours.
Thank you, Dr. Martin and Clay. Can you guys see my screen?
Yes, we can. Thank you.
So thank you again for this privilege to speak with you guys here. Just briefly about me. Although I was born in Cardiff in Wales,
for interrupting you before you start, but we're seeing the presenter view. If you'd like to just switch, it's
sure.
at yes. I think if you hit play from start. Oh, okay, at the bottom, do you see those 5? Oh, sorry. Go ahead.
Is that better?
Yes, thank you.
Cool. Yep. So I was born in the UK and I grew up in Egypt mostly until the age of 12 when I moved to South Dakota. When I was in medical school, I decided I wanted to be a pediatric surgeon, which is an additional 9 years of training. So I did general surgery at the University of Michigan and 2 years of pediatric surgery in Texas. And as pediatric surgeons, we treat infants and premature babies all the way up to young adults. And we focus on congenital defects, childhood cancers, but also trauma and basic conditions. So my journey working in Palestine began in the summer of 2017. I was near the end of my general surgery training, and honestly, I was quite burnt out and feeling disconnected from my purpose. And I wanted to find a way to give back and especially serve folks in need in places that and communities that have shaped me. So I decided I wanted to focus on treating patients in Palestine. I was able to organize a 2-week mission with PCRF to Hebron with a surgeon and an anesthesiologist that I trusted. And the following year, I returned to Nablus, this time in the northern West Bank, a beautiful city, where we also had a great mission there. And these 2 trips kind of early on in my career were quite impactful and really shaped kind of the vision for my career and my trajectory. After COVID, PCRF asked me to return to Palestine to perform a needs assessment. So I spent 2 weeks traveling in the West Bank, visiting all the Ministry of Health hospitals that perform pediatric surgery. And I got to meet with all the pediatric surgeons, a lot of administrators, and really understand kind of what are the issues that they were facing there. And this opportunity allowed me a permit into Gaza. So that was my first trip into Gaza in the summer of 2022 to Shifa Hospital, which Dr. Dalton had mentioned. This was really the premier kind of hospital in all of Gaza where you could receive specialized care. So I spent time there with the pediatric surgeons, trying to understand what are the issues they're dealing with, where can we help to grow the capacity there. Just briefly, and this may be familiar to many of you, but this is all pre-war data. I just want to show you how dire the conditions were already before the war. But Gaza is a very small, densely populated area. It's 2.1 million people, and a strip about 25 miles long by about 4 to 7 miles wide. And it's a very young population with a median age of 17 years. Very high poverty rates. At least half the population is considered, under poverty with difficulties in meeting basic necessities, and some of the highest unemployment rates in the world. Most households received about 4 to 8 hours of electricity per day. So there's always constant electricity cuts, and most of the groundwater was unsafe to drink. So most people depended on water trucks bringing in water to their homes and to the hospitals, of course. So some of the challenges, facing the field of pediatric surgery in Gaza is, first, there's a very high incidence of congenital disease. So, and this is higher than many areas around the world. So it's about 8 to 9 cases for every 100 birth almost. And some of the factors that play into this are genetic issues. It is a closed off area, so there's a limited gene pool, but also environmental toxins and poor maternal health. And compounded with that, you have very high neonatal mortality rates. So not only are we dealing with babies that have congenital anomalies, but we have very high mortality rates in the NICU. And these account for almost half of the under 5 death in Gaza. And then on top of that, you have very limited OR capacities. So that leads to very long wait times for elective surgery. So before the war, if you had an elective condition, you had to wait a year to a year and a half to have surgery, and that includes children and adults. So you can imagine that time that you're waiting. Patients are deteriorating, diseases are getting more complicated, which then makes their surgery and their outcomes much more difficult. And really, the area that I was focused on was there was a severe lack of specialists. In all of Gaza, there were 2 surgeons that were considered qualified to perform, the necessities of a pediatric surgeon. And then there were several that really could just deal with the basics. So there's a huge shortage of pediatric surgeons. And because Gaza it was closed off, there's no way to folks to travel and become specialized. So in 2022, Shifa Hospital started a pediatric surgery training program where they would train through residency a year. And this is where I became involved to help train the residents and form a collaborative partnership. My mission was to strengthen pediatric surgery in Gaza through collaborative partnerships, hands-on training, and mentorship of the trainees. So what we started doing was, we obtained access for the trainees and the surgeons to online literature, educational tools, published guidelines. And we started holding a twice a month conference where we brought surgeons together from Gaza and the West Bank, and some of these folks had never even interacted before. And we started having these conferences to share cases, to discuss challenging patients. And then we developed an in-service exam, and we started planning twice a year visits where I would go to perform complex cases there in collaboration with the surgeons and to train the residents and the junior surgeons. So I had 2 missions in 2023 to Shifa and the European General Hospital, and these were really very fruitful missions. We had some very complex cases that we dealt with, and we were able to spend a lot of time training and working with the surgeons there. On October 6th, this is a picture of me checking in on the team as they were performing a laparotomy. So I said goodbye to the team and I exited Gaza to fly home. And obviously the next day, the war broke out. And some of this data has already been shared, but at least 70,000 Palestinians have been killed and 170 injured. There's many more under the rubbles. And there's still death going on since this ceasefire. And most Gazans have been displaced. When you talk to folks on the ground, almost no one is living in their original home. And the few that are extremely lucky. And many people have been displaced more than 10 times during the last 2 years. There's been at least 1,700 healthcare workers that have been killed. And as Dr. Dalton showed, the damage to the infrastructure is just unprecedented. There are really very few hospitals left standing, and those that are standing are at best partial capacity. So, like I said, Dr. Dalton showed some images of the destruction. These are 2 hospitals I used to work at. Shifa was destroyed early on, and the European Gaza Hospital later on in the war. So I was with Dr. Dalton in the January trip. We were there earlier this year during the second ceasefire, and I was able to return recently in September and October, right before they announced the current ceasefire. But some of the challenges that he alluded to were, it's difficult to get these spots to get in. The security clearances can be very difficult to obtain, and they now are rejecting about 75% of the physicians that apply. And they actually limit what you can bring in. In January, we could bring in suitcases full of stuff, but our last trip, we were not allowed to bring in any surgical equipment or even food. So and during these last 2 missions, I was in the south of Gaza working at Al-Aqsa Hospital, but also Nasser Hospital and the European Gaza Hospital. And if I were to describe the state of pediatric surgery, I would say it's near collapse at this time. There's few surgeons remaining, and that's because of displacement, hospital closures, but also these surgeons are people, and they've had family deaths that have now forced them to stay at home or in their tents to care for their loved ones. And also, some of them are just burnt out. You can imagine 2 years of this constant nightmare. It's a lot for a surgeon to handle. And during these 2 years, there's been almost no elective cases. So there is a severe backlog of children that need surgery for congenital anomalies or basic issues, and even just sequela of these traumatic injuries. And there's just a severe shortage of pretty much all essential surgical equipment. This was a typical kind of scene during my time there in this last mission. There was constant bombing, after which you would get these mass casualty events. So you get all these ambulances that descend on the hospital. This is at Aqsa Hospital in the center of Gaza, which is kind of one of the main trauma centers right now. And during these mass casualty events, our job was to walk through the ER and to identify children that are injured, that need surgery, and also children that have injuries that are non-survivable. And these scenes, they can be quite difficult to process. And I do want to just say that there will be some potentially graphic images, so just as a warning for viewers. But we could spend the next hour talking about the trauma and all the injuries in Gaza, but I really want to just spend a little bit of time focusing on what happens after the trauma, because for many children, the initial trauma is just the beginning of a long and difficult journey for them and their families. This is Yusuf. Yusuf is a 12-year-old who was playing in his tent. You can see here a picture that his uncle was showing me. A missile landed right in the middle of the tent, killing everyone in his family. And he was operated on at Field Hospital, and then 10 days later, transferred to our center. And when I first met Yusuf, his incision had broken down. You can see intestines were protruding from his incision. And on top of that, he was leaking stool from his flank where he had a shrapnel injury. So we had to operate on Yusuf emergently to get in there and find the area of try to get source control and try to put him back together. And this is not a unique story. There are many children just like Yusuf who, because of their very poor nutrition before these injuries happen, which is then compounded by further worsening of their nutrition after the surgeries, they then have breakdown of all the repairs. They have surgical site infection. In fact, almost every patient gets a surgical site infection in Gaza at this time. So these children then have to have subsequent procedures to repair some of their original surgeries and try to get damage control. And on top of that, many of these children will have orthopedic injuries and soft tissue injuries and that need further surgeries. This is Omar. Omar was a 13-year-old whose house was hit by a tank, and he had to have emergency surgery. Had multiple injuries to his intestine, and unfortunately, a lot of these repairs broke down. So he developed what we call intracutaneous fistulas, where parts of the intestine had opened up, and he had unfortunately very limited intestine, so couldn't really have a full amount of nutrition. And the only reason he survived was that his mother was continuously basically feeding him almost on the hour just to get enough nutrition in him to survive long enough. And it took us 5 hours to be able to reconstruct everything, and he was lucky to go home, or really to his tent a few weeks afterwards. And these are all children that sustained traumatic brain injury from various types of injuries, and these children in the best of conditions can be very challenging to deal with and require high resource type care and rehab. And unfortunately, in Gaza, this simply just doesn't exist. So all these children were basically kept alive long enough in ICU to subsequently die from sepsis. But obviously, we're focusing on all the traumatic injuries, but what about all the kids that have congenital and non-traumatic injuries? Well, these kids really have very limited access to care. And this is just one example of a child, a 3-year-old, that I met this most recent trip. He was having severe respiratory distress for a period of several months. And you can see here he has what we call abdominal breathing. He's using his abdominal muscles to breathe. And he had been having such severe distress, he was starting to lose weight and really struggling So his mom brought him to the hospital where we discovered a very large cyst coming off of his lung that needed emergency surgery. And there's many children just like this child who simply just don't make it to the hospitals in time. As pediatric surgeons, we often rely on parenteral nutrition. So for the non-doctors, that's IV nutrition that you receive when you can't have nutrition through your gut. And these are examples of babies that we operated on that have intestinal atresia. These are congenital conditions where intestine doesn't develop normally, and it can take weeks and if not months for the intestine to recover and for them to be able to have formula or milk. And the only way we can get these children to survive is with TPN. Unfortunately, in Gaza, that just doesn't exist. So these children all became weak over time, and unfortunately, they died from sepsis as well. And the last story I'll share with you is about Sham. Sham was a 2-year-old that I met in January. She had Hirschsprung's disease, which is a colorectal condition that affects part of the colon, and these children need resection. And there's a lot of these cases that we deal with in Gaza as a higher incidence than most places in the world. But we operated on her in January, and she had a great recovery. And she, in March, they were living in Rafah, and she developed a severe gastroenteritis. So she started having a lot of diarrhea. And because of the military restrictions on movement, they could not bring her to the hospital at night. So they had to wait till the next morning. And by the time they were able to find transportation, she had already died. And there are many children just like Sham who have very easily preventable, very easily treatable conditions that, and their deaths can be easily prevented, but they cannot reach care in time due to restrictions on movement of people and really all the closures of the hospitals in Gaza. So I know it's kind of a heavy presentation. I don't want to just show all the destruction, but I do want to just offer some actions. And this is not something I came up with. This is really what a lot of groups are prioritizing. But for the immediate kind of needs, we really need to reopen and streamline the crossings for medical supplies, because even now there's still a huge shortage of all these things. And we need to continue to deploy mobile and field hospitals and bring in emergency surgical teams. And we need to put certain things that need to be prioritized for the hospitals, such as the blood banks and the dialysis units, as well, all the surgical needs. And then kind of in the short to medium term, the infrastructure obviously needs a rapid repair to expand the healthcare access, and all the supply chains need to be rebuilt. And just focusing on workforce continuity and well-being is a huge task on its own. And there are many groups now working on telemedicine partnerships and kind of special mentoring type relationships. These are the things that we can spend hours talking about, and I hope we do have the opportunity to do so. And I really draw my inspiration from the folks on the ground. These are just some of the examples of the surgeons, or some of the pictures of the surgeons that I've had the privilege to work with. And really, they're all heroes in the way they've shown up during the war, and the way they've shown resilience, and honestly, in ways I just can't imagine. All these folks have suffered. Dr. Possam here on the left, he lost his entire family early on in the war, and he told me he was completely burnt out and just unable to work for several months, but really had to find the strength to come back. And he's a thoracic surgeon and also a hospital. He does amazing work there every day. Dr. Omar in the blue scrubs, he was a pediatric surgeon at the European Gaza Hospital. His brother, who was in Rafah, him and his wife were shot in front of their children, and he now takes care of these children. But he has continued to work, and in fact, he was living out of the hospital for 3 months with his family during the war, and he worked the entire time and provided amazing care to his patients. So there's many stories like this. If you just walk around the hospital, I mean, everybody honestly is living out of a tent. Everybody's displaced. Everybody's suffering, but they've all shown up in really amazing ways. And really, when I think about the situation in Gaza, it's hard for me to be hopeful, to think of a better future. But when you see parents in Gaza and you see how they love, they show love for their children, and they fight for their children, and they protect them even when they have nothing, you really can't help but feel inspiration and to feel the hope. And I think we need to honor their resiliency and by showing up, by continuing to advocate and continuing to work so that these children can have a dignified and beautiful life. So thank you so much for this opportunity, and hopefully we can have some time for discussion.
Dr. Halowish, thank you very much for sharing the story, what you've done, what you've seen, and the stories of Sham and the surgical heroes that you work with, individuals who we cannot imagine the resilience, what they've endured, and the resilience that they have exhibited for the care of their fellow Palestinians. It's a human story, a beautiful story in the midst of unspeakable tragedy. And thank you for giving us and sharing paths forward, which is what we are going to get into in the Q&A at the end of this, and what we can actually do. And with that, I'd like to turn it over to Dr. Faraz Sidwa. Dr. Sidwa, thank you again also for joining us today and for sharing your perspectives on child casualties in the Gaza Strip and what we can do moving forward. So, sir, the floor is yours. Thank you.
Thanks. Hopefully you can see my screen okay.
We can.
So I was asked to mention a few things about myself, but I think in general, my attraction to global surgery and humanitarian work is it just kind of came out of my life's experiences. I happened to go to college in the year 2000, and that's when the Second Intifada broke out. It was a politicizing time, and I ended up also working in Hebron actually as a medical student, and even before that, after I graduated from university, I actually lived in Israel and the Palestinian territories for about a year. And I think these things kind of, your life just kind of shapes you into someone who can probably do some good in a particular situation. And when that situation comes around, it's worth taking action, I think. And I'm hopefully doing that to some degree. This was already kind of talked about, the particulars of Gaza before October 7th, but just not again, I don't want to rehash everything Ehab said, but Gaza is an incredibly small, incredibly densely populated, incredibly poor place. In 1948, about 250,000 Palestinians were expelled from the newly created state of Israel into the Gaza Strip, and there were only about 80,000 people who lived there. So today, about 70% of people who live in Gaza are the refugees or their descendants. It's also a very, very young place. Like you have said, it's about 50, well, who knows now, but before October 7th, about 51% of people were under the age of 18. Very few people were over the age of 65. There were some, but not many. Extreme political repression since not just 1967 under Israeli occupation, but even since 1948 under Egyptian occupation. Since 1948, and again, including under Egyptian occupation, plenty of Western visitors who have gone to the Gaza Strip have described it as a concentration camp, including Israeli generals, including American military men, including UN representatives, including Israeli sociologists. It's really quite a remarkable thing how many people that same image crept into their mind of Gaza as a concentration camp. We all know that it's under military occupation. De-development is something that it's kind of a unique phenomenon that's been undertaken in the Gaza Strip under Israeli occupation. If anybody wants to read about it, Sarah Roy's book, The Gaza Strip, The Political Economy of De-Development, is definitely the best resource on the topic. But it's kind of amazing to see the systematic and really sustained effort of destroying not just Gaza's, but all of Palestine's economy as it could possibly be separate from Israel's. And finally, since about 2007, Gaza has been under a land, air, and sea blockade, which really has no precedent in modern history. Since then, since October 7th, Gaza has become just kind of a different planet from anything else that's going on in the world. Gaza is one of the deadliest places, or Gaza is the deadliest place in the world for both civilians and aid workers. It's also one of the most dangerous places in the world to be a child. There are plenty of places in the world, like we've heard about Sudan, we've heard about Ethiopia, there's Congo, there's Myanmar, there's South Sudan. There are so many places where children are bearing the brunt of adult human viciousness. But Gaza is in some ways unique. Uh, Gaza is an incredibly deadly time for journalists. I actually was just writing something for an American news site, and I noticed that as far as anybody can tell, it's actually more dangerous to be a journalist in Gaza than it is to be a Hamas fighter. Gaza, the Clay really showed the just absolutely fantastic destruction of the Gaza Strip. There's nothing to this degree. There's nothing that's ever been done to a built-up area like this. Just so people understand, something like 80% of Gaza's buildings are damaged or destroyed, and by damaged doesn't mean a bullet hit them. It means they're unlivable. That's far worse than just the destruction even of Hiroshima after the atomic bombing, which again is quite a shocking thing. Gaza's easily the thirstiest place in the world, at least of 2 million people. Oxfam has estimated that since October 7th, there's been less than 4 liters of water per person per day available in the strip, and not for drinking, but for all things humans use water for. And incidentally, none of it has been fit for human consumption. I think we all know about the declaration of famine, which I could say a lot about, but we all, famine's bad and it's been going on in Gaza. Gaza is probably one of the most wounded places in the world. It's hard to find comparative statistics, but it'd be surprising if there was another close example. And finally, Gaza has undergone what has to be the most direct and sustained assault on a healthcare system that has ever happened. At least since the time of Genghis Khan. This is just to illustrate for people the situation of famine in Gaza, because we all know famine affects children primarily, or not primarily, but most severely. If nothing is done, and so far as anybody can tell, really nothing of substance has been done to reverse this problem. Uh, Most of Gaza, if not all of Gaza, will be in famine now. Basically, we just don't know because there's actually no way to really collect data. Even the IPCC's own attempts really have failed, and they had to make kind of a presumptive diagnosis of famine in May when they put this information out. And then just to illustrate the degree of the assault on the healthcare system, prior to October 7th, 2023, Ukraine was the world's deadliest conflict for healthcare providers. In that, this information all comes from the UN Humanitarian Data Exchange. In the 1,216 days of the war in Ukraine that's included in the database, it's up till July of 2025, the 310 healthcare workers have been killed in Ukraine. You can see that rate of killing over on the right side. In Gaza, in about half the time, about 673 healthcare workers have been killed. And like Ehab said, it's actually over 1,700, but this is what's captured in the UN database, and this is comparing apples to apples. That's happened in about 628 days, and if you adjust for the size of the healthcare workforce, the rate of killing of healthcare workers in the Gaza Strip is 100 times higher than it is in Ukraine. This is just completely outrageous. We don't have good numbers from Tigray, from South Sudan, from Yemen, from other such places, but it's unlikely that this level of killing is matched anywhere else. And again, I just want to be clear. That is not to say that the killing of healthcare workers is okay in those other places or that it should be tolerated. It absolutely should not be. But this is to illustrate because, and I'm an American, the United States is deeply involved in this, and this is one of the most severe, if not the most severe, such attacks on healthcare that's going on anywhere in the world. And then I know we're short on time, so I won't go into the extreme details of this, but these are all of the comparisons that I can find for armed conflict in the last 20 years that even remotely compare to the killing of children in the Gaza Strip. And so the Russian invasion of Kharkiv and the Russian air attack on Syria in those have both been studied very intensively by a British non-governmental research firm called Air Wars, and so have the first 25 days of the attack on Gaza. And you can see the differential rate of killing of children in these, again, population adjusted. The rate of killing of children in Gaza is orders of magnitude higher than it is in either Ukraine or even in Syria in 2016. And Syria in 2016 was the deadliest air campaign Air Wars had ever studied prior to Gaza. There's just it's just a shocking level of child killing that is happening right in front of our eyes. And I think it'll probably be best if we get to questions and answers, but I think we should all ask ourselves what it means about our own societies that we are, and especially the Western societies, what it means that we are so deeply involved in these kinds of actions against children, and not only what it means about our willingness to help them or to rebuild or to do something like this, but even just to take our boot off of their neck is something that I think we should all consider.
Thank you very much, Dr. Sidwa. That was another outstanding presentation, gripping, direct, and focused. And you really laid out that this catastrophe is unmatched in history, in modern history at least. With that, I'd just like to start with a simple question for all of you, and we'll go in the reverse on solutions. And all of you shared some of them, but I wonder if you could share with us what we could do now and what pressure we need to enable children, to start off with, to be able to receive the care that they need for the acute injuries they have, but also for the ongoing care that they cannot receive. Where do we go? How do we get it? What are the next steps so those children that you've all shown pictures of can receive the care that they have? And I'll start maybe with you, Ehab, and then go to Clay, and then Feroz. Ehab, please.
Yeah, I mean, I think in terms of what we can do here on the ground, obviously advocacy is kind of the main tool. It's pressure needs to be placed, and I don't want to get into politics, but there needs to be pressure placed by Americans because as Dr. Sedwa and Dr. Dell mentioned, we are kind of the primary folks funding this genocide. And I think we are responsible to find ways to end it. So I think it's going to come from the people, using their voice collectively to advocate and to push the politicians into action. And that's easier said than done. And I'm worried because I think the movement is losing some of its momentum. We don't see it Gaza being talked about in the news anymore, even though there's still ongoing bombings, and even though the conditions really haven't improved that much. So I think it's going to be grassroots movements to pressure politicians to affect change, which unfortunately is not going to be a quick solution. I think it's going to take a long time before the U.S. changes its policy.
Thank you, Dr. Halowish. Dr. Dalton.
I very much agree with what Dr. Howard was saying. I think that we're in an interesting moment, I think, in the conflict right now. It does look like there is very slow evolution on the part of American politicians in terms of acknowledging what has actually taken place in Gaza and our role in it, actually on both sides of our political spectrum, which is quite unusual. But I think we run the risk of having arrived at what seems like a ceasefire that may have some staying power. It begins to fall off of people's screens, out of their awareness, and I think there's a risk that it starts to lose the attention that it still very much needs. And so I think, what can people do? I think that Americans do have a sort of outsized role to play because of the role that our government has had in sponsoring the conflict. And so I think that for people in the United States, remaining active and vocal in terms of applying pressure to your political leaders, call your representatives, call your senators, write letters, apply political pressure in an unyielding fashion. And then I think also just keeping the issue alive in terms of talking about it, friends and family, maintaining awareness, sharing what you know about it, perhaps something that you learned from these presentations here. The detail that was provided by Dr. Sidwa and Dr. Halowish is just searing. And what can we do with that aside from sort of be shaken as people? We can maybe take some of those details and use that to share. I think attention is the most important resource in terms of directing real material aid. If nobody's paying attention anymore, then I don't think much aid will follow. And what is really needed ultimately is lifting of the restrictions on material aid that are coming in. They just there's need for everything, to rebuild, to reestablish the healthcare system, to reinstate support for children for all of their various needs. There's just going to you can't do that without things that need to come in from outside, and so there must be improvements in aid flowing in. Thank you.
Thank you, Dr. Dalton. And these are political choices, one way or the other. So, as you said, we can use, particularly humanizing the stories and using the human stories. You can't but hopefully be moved by them. I'm going to go to Dr. Sidwa, and then I'm just going to let, because in the interest of time, because I know you all been very kind with your times, we're over time, so I'll just go back and backwards and give everybody a minute to respond, if that's okay. Please, Dr. Sidwa.
Yeah, I think we have to, and Ehab said he doesn't want to get into the politics, which I understand, even though he's wearing a University of Michigan lanyard in Ohio. But we have to, and everybody has to take their own ability to manage risk and things like that. I understand that, but there's an Israeli Holocaust and genocide scholar named Raz Siegel. He wrote a good article in the London Guardian just 3 or 4 days ago. And he's, and this guy's a Holocaust scholar. He actually wrote, we don't live in a post-Holocaust world of never again, but we live in the same world that led to the Holocaust of again and again. He kind of goes on to point out that it's an interesting analysis, I think, that and this only applies to the Western powers, obviously, but the factors that led to the Holocaust were white nationalism and nationalism itself, or kind of the desire to create homogenous ethno states. This is a very, very ugly idea that has led to some of the world's greatest atrocities. And Segal himself says that the kind of the crowning manifestation of this is Israel's ongoing assault on the Palestinians. Uh, and he says that the Nuremberg trials didn't address this, the Tokyo trials didn't address this. No process, no actual mechanism that we've ever had in the Western world has ever addressed these problems. Um, and he actually goes on to say that in this context, for Israel and its supporters, the Gaza genocide is a model. Now, those are his words. But he goes on and he says, and I'll just quote him and then I'll stop talking because it's worthwhile for people to hear. But most people around the world don't want this future or this present. Most people see through the doublespeak of their leaders who claim to meet in Sharm el-Sheikh to make peace as they continue the flow of the means of destruction. Most people know that their governments, left and right, don't represent them, don't even care for them, nor for the future of their children. It kind of goes to what Ruth was mentioning at the beginning, that the French general was saying, you have to get ready to sacrifice your kids in war. Well, it's up to people themselves. He says, most people know that day is not night, and they refuse to say otherwise. And many, many people around the world have taken to the streets, risking arrest, violence, loss of jobs, facing stigmatization as anti-Semites, and driving apart from family members and even close friends. But they have shown up, and they continue to show up because the struggle continues for Gaza, for Palestine, for their lives, and indeed for the entire world. And I think that's correct, essentially. I think we have to show up, and I think we have to just decide to take charge of our own lives. Otherwise, we're going to continue to subsidize the mass murder of children in Gaza and plenty of other places.
Thank you very much, Dr. Sidwa. That's spot on. And it's a powerful call to action. So I'm just going to go just because we run out of time now, but I would like to make sure that each of our speakers, those that are on from the first session that Dr. Gibson led, and those on this session, that you have a minute for any closing comments. I'll start with Dr. Ines, Dr. Martha, and Dr. Tunde, and then we'll go to Dr. Dalton, Dr. Halawesh, and Dr. Sidwa. Dr. Ines, please, if you have a minute.
Yes, thank you. And thank you for the all doctors that are providing, the heroes that are providing their services for the children and individuals who are in need. Well, I just want to say that the war definitely leaves an invisible marks inside of us, inside of children, families, and this can be over generations, not only just for children. And yeah, we should try our best to prevent children from witnessing this or being part of this. And we have a Sudanese proverb that's one hand cannot clap. So when we gather, that will be more efficient for supporting children. And thank you.
Thank you very much, Dr. Mustafa. Please, Dr. Martha.
Okay, okay, thank you. I'm so honored again to listen to those amazing speakers, their work, their extensive work, incredible work. Yes, I would say that the solutions are at our hand, on our political leaders. We know that US is a world leader, so the governors should put pressure on our leaders, and also still US can act as a mediator, not only pressurizing the leaders, also can act as a mediator, because there are calls from both sides. It's not going well. It's not going smoothly. There are like in and out. So the mediator should be a world leader who can put pressure on politicians. And so, for example, US aid, there is a cut of fund from the US aid is further fueling the problem. So those funds are very important to give temporary solutions for millions of lives living in poor countries like ours. So I would say that US governors kindly reconsider those US aids and other donations to help millions of lives in Ethiopia, because they are dying of malaria. People are dying of HIV, and other maternal child health services are not going well. So I would say that it's on US hand and other governors who can put pressure on politicians. Thank you.
Thank you very much, Dr. Solomon. Dr. Ogunbozi, please, if you were still on.
Yeah, thank you again for this opportunity to join this distinguished audience. And thanks to all the doctors and all the great thing you're doing out there. I think we've all said pretty much something similar, or a common theme, and that's holding leaders accountable at whatever stage or forum you want to speak to. In Nigeria, definitely some of the pressure from the US government is hopefully yielding some results. But I think also in all the places that we've talked about, it's down to our leaders, whether we elect them or choose them or not, doing the needful for the betterment of humanity and the good of our children and our women. And the more pressure we can put on them to do the needful, I think the better. This crisis, this mayhem, this assault on our humanity has gone on for far too long. And it's still down to the leaders doing the needful. And we just have to find ways to hold them accountable. Thank you.
Thank you very much, Dr. Ogunbozi. And we'll turn it over to Dr. Dalton, please.
Thank you, Dr. Martin. I'd just like to say that I'm profoundly humbled to share this panel with the other physicians who have spoken. Truly heroic, selfless work in all of these various conflict zones. And so I want to thank each of them sincerely, wholeheartedly for the work that they continue to do and have done. And then I would say that I think as important is continuing to bring awareness, attention, and light to these situations. And so thank you to CUGH and to you, Dr. Martin and Dr. Gibson and everyone else who's been involved in putting this together. I think sharing with the world what we've seen and what we know, I think is one of the most powerful avenues to change. So thank you.
Thank you very much, Dr. Dalton. Much appreciated. Dr. Halawesh, please.
Yeah, I was actually just going to echo what Dr. Dalton said. There's a need to continue, I think, to advocate and to document what's happening. And I was inspired by Clay's journalism and the work that he's done. He's one of the kind of the people is be able to document kind of destruction in northern Gaza through his New Yorker timepieces, and also been inspired by some of the work that Dr. Sidwa has done in amplifying the voice of folks on the ground in Gaza and really speaking out. So I think we need to continue to do that, especially as we mentioned with the ceasefire. It's really going to take away the spotlight from Gaza. I think we need to keep pushing people's stories and continue to advocate for them.
Thank you very much, Dr. Halowesh. Dr. Sidwa, you get the last word before Dr. Gibson and I do.
Yeah, I think it's just important for everybody, and this panel really adds to this. Like I learned a lot from listening to all of you actually, and we need to know what is driving these conflicts. Otherwise, we can't stop them. We can bandage people up afterwards, but it's better to just stop them from being shot and killed and raped and all sorts of other horrific things that are being done to everybody. And that's I think why this kind of panel is so useful, so people can learn about Sudan, Nigeria, Ethiopia, Congo, Myanmar, Syria, Ukraine. You could go on with the list, unfortunately. Um, and I just would encourage everybody to take the information you've learned and try to actually put it into action. Try to petition your policymakers. Try to make your neighbors understand what's going on. Um, Cross disciplines. There's no reason to stay in the silo of medicine. There's not that many doctors in the world, but there's a lot of other people. And and yeah, I think we can make a difference if we choose to, but it takes stepping outside of most of our comfort zones. Like Clay's a trained journalist, so maybe he's different, but I personally don't like being involved in that kind of work, but it's unfortunately it's just necessary. It's another part of our at least in the West, we all take the Hippocratic Oath, and that involves some measure of advocacy for your patients, which is just necessary.
Thank you very much. Thank you, Dr. Sudan. And that's what Rudolf Virchow said, right? But politics being a social science, you're carrying a larger stethoscope once we get into politics, which is just where we should be. With that, I'll just turn it over to Dr. Gibson for a final comment before I close it up. Please, Dr. Gibson.
So I'd like to thank all of the people who have joined us online and who are watching this panel recording after the fact. I think that one of the main lessons for me in listening to all of this is the importance of even one individual's work in bearing witness to what's happening on the ground, and the importance of understanding these geopolitical forces. One of the things that Keith and I were discussing as we set up this panel was this session is, one one piece of work, and kind of collectively we are moving forward in a variety of initiatives. One of the things that's come up a number of times on the chat and on the feed is for individuals' emails, addresses who are on the panel, and we didn't think about that in advance. But Rose, if it's okay, I'll enter both yours and my email into the chat to everyone. I have volunteered him. And so you are welcome to reach out to us after this panel in addition so that we can move forward with discussions about what needs to happen next. And that was very much the goal of bringing all of these exceptional panelists together. And with that, Keith, I'll hand it over to you.
Thank you very much, Ruth. And on behalf of all of us at CUGH, I'd like to thank all of our outstanding panelists. I mean, you're more than panelists. You are actually, as many of the folks have said, you're all heroes. I know you would never probably consider yourself as such, but you are. And you give care and voice to the voiceless in ways and places that people don't see, but you do it because it's the right thing to do. And you have given yourself to do that. And so you're really an inspiration for the rest of us. I'd like to thank Elizabeth Hourani on my team who produces this, Elizabeth who co-created this and really did the lion's share in putting this together also. And finally, this session is going to be on our website in 2 weeks' time. It'll be shared with CUGH's network of 36,000 people worldwide. It'll be shared well beyond that in all of our other platforms. I would just encourage all of you to please use it. Conflict and war is a political failure. is a failure of politics, which means that all of us can actually mold and shape that in a different direction. People have to get elected, and it's we who are the electors who make that happen or not make that happen. So each and every one of you have a voice. Please tell the stories in the way that we've learned today of our speakers, how they've told stories. Share the voices of the voiceless, show their pictures, use visuals, and be persistent. Repetition is absolutely essential in what we do because that repetition, again, gives power and voice to those that don't have. And finally, for those who are in the region and are in the countries that could be helping out the people in Gaza and also in the other conflicts that we saw today, step up to the plate and help these people now. They need your help. They need your assets. Otherwise, they will not be able to have, I think, as Dr. Hallower said, the lives that they shouldn't deserve to have, like the rest of us want and deserve to have. So with that, thank you all for attending this session. Again, follow us at CUGH.org. Come to Washington next year. It's at our annual conference, and we hope to see you there so we can continue to work on this issue, which we will continue to do. Thank you so much.